Hey all, Eric Christensen here, pharmacist with the Real Life Pharmacology podcast. And I'm back at you today with another episode. And I'm going to cover Oseltamivir, which is a medication that is indicated in the treatment and prophylaxis of influenza. It's really, at this point, our go-to in clinical practice. Obviously, that can change over time, so certainly take a peek at guidelines and be sure to look out for any changes in the future. But the brand name here is Tamiflu, and the way this drug works is it inhibits the viral enzyme neuraminidase. Now, this enzyme is necessary for the virus to basically be able to release more virus, proliferate, and obviously go on and continue to infect other cells throughout the body. With influenza, common classic symptoms, fever, body aches, upper respiratory symptoms. Those are really the hallmark symptoms as far as an influenza infection there. Now, with treatment and prophylaxis, you've got to remember that there are different doses. And specifically talking about adults, usual dosing is 75 milligrams once a day, and that's usually going to be your prophylactic dose for a normal, healthy adult. For treatment, 75 milligrams twice a day. And prophylaxis is generally going to be for a longer period of time. Treatment of influenza is generally only going to be for 5 days. And if you think about that, that really makes sense. The usual course of influenza is probably in that 5 to 7 day period. I can speak from personal experience. I had influenza several years ago now. And first off, it's not very much fun. The fever and the body aches were definitely intense. But personally, I did have symptoms kind of extend, lingering respiratory symptoms extend past that 5 to 7 day period. Usually the fever, the body aches, they kind of go away after that 5 to 7 day period. Again, that's for most typical, younger, generally healthy patients. Now, an elderly, that's the geriatric patient population that I work with most. Those lingering symptoms can be really problematic, and there's really a big risk of secondary pneumonia and much greater risk for complications with an influenza infection. That's why when talking about vaccination, those are the patients, the young and the old, that we really worry about as far as significant impacts, as well as immunosuppressed and other patients at risk too. So the CDC, I did want to mention, Centers for Disease Control is a good resource for how and when to use these agents, or when to use oseltamivir for prophylaxis. So definitely go keep tabs on that, keep up to date with when prophylaxis is and isn't recommended. Important education point as far as treatment, I've definitely seen this come up before, is how soon do you start the drug as far as treatment, and when's kind of that cutoff time for when the drug probably isn't going to be that effective anymore. So most of the time we want to get that drug started within 48 hours. Okay, that's really our target. And that's of initiation of symptoms. So once the patient starts experiencing symptoms, if we're going to use treatment with oseltamivir, we want to get that drug started within 48 hours. Now, obviously, that isn't always, going to be acceptable, because patients may not come, they may try to tough it out for a day or two, and then if you're at that 48-hour period, or in that gray area, what do we do? And so I have seen oseltamivir given beyond 48 hours. Generally, that's going to be in higher risk patients, but there again, there's going to be kind of some clinical judgment as to whether we give it, maybe if it's on day 3 or 50, 60, 70 hours post the onset of the first symptom there. So kind of a challenging clinical decision there sometimes. Important to note dosing. I did mention kind of the standard dosing. There is dose adjustments for kidney function changes. So very, very important to remember that. I generally have to look it up to jog my memory. But 30 to 60 mils, at this point it's 30 milligrams BID. If you've got a patient with a creatinine clearance, 10 to 30 mils, that's 30 milligrams once a day. So again, need to check those dosages out, need to look at patient factors. Prophylaxis, the dosing is a little bit less, which kind of makes sense. So 30 to 60 mils per minute, 30 milligram dose, and 10 to 30 mils is 30 milligrams every other day. Pediatrics, I'm not going to get into that into too much detail. It is a weight-based dosing, so be sure to look at that if you've got a pediatric patient that we're considering treatment or prophylaxis. Let's get into adverse effects a little bit. In my experience, I've seen that the drug is usually pretty well tolerated. GI adverse effects, nausea, vomiting, that can happen. Again, not incredibly common, but probably one of the more common ones. Headache is reported in the literature. Rarely. I have seen this come up once or twice in my career anyway. Psych issues, psych changes, delirium type symptoms have been reported. So definitely, keep that in mind. You may want to alert your patients to that if they notice any psych changes. That may be a complication with the medication. Maybe, a little higher risk in patients that maybe have poor kidney function and trouble clearing the drug. Whether that's due to the actual drug or due to influenza, which, obviously could cause some stress to the body, that's maybe difficult and challenging to decipher. And there may be some question as to what's exactly causing these psych changes. Is it the infection itself or is it the drug itself? So again, just something to look out for, something that's definitely been reported there as well. So let's take a quick break from our sponsor, meded101.com. If you're looking for resources, pharmacist board certification, study materials, BCPS, BCGP, BCACP, BCMTM, and NAPLEX, we've got all those resources. Go check out meded101.com/store, and we've got links to all that. If you're a nurse, pharmacy student, med student, physician looking for clinical pearls, case studies, go check out our books, which are also linked up at that link, meded101.com/store, S-T-O-R-E. And good resources there for anyone looking to pick up some clinical practice pearls and really get some real-life education, if you will. So again, meded101.com/store. You can check out those resources. So finishing up on drug interactions, there really aren't a ton of clinically significant drug interactions with oseltamivir. So that is certainly a good thing. Something that has come up before, or I have seen it asked anyway, is the concern about giving flu vaccine, with or after giving oseltamivir. And it is important to note that this drug can blunt the response of the flu vaccine. And again, I don't think this situation comes up really often, but there's probably about a 2-week period that they recommend not giving the flu vaccine in patients who have recently had this medication for some reason. So an example here where I might think of it is, maybe somebody who's getting prophylaxis for some reason. Maybe they've been in recent contact with somebody who has had influenza, and we want to do prophylaxis for some reason. Well, giving that flu vaccine later on may be appropriate still, but we may want to wait 2 weeks just to make sure that antiviral agent is out of the body, and make sure that flu vaccine, we get the most bang for the buck. We want to make sure the drug doesn't inhibit the activation of the immune system and inhibit the immune response to that vaccine. So just a little clinical quirk there. Again, not going to probably come up real often in your practice, but something I wanted to mention. Probenecid is an agent. I have, honestly, it's been a long, long time since I've seen it used. It can be used in gout to kind of, lower the risk of a gout flare there. This can increase concentrations of oseltamivir, so keep in mind some of those adverse reactions I mentioned. We may be at an increased risk if these agents are being used together. One other one, interestingly, oseltamivir is actually a prodrug, and it's possible, theorized anyway, that clopidogrel could decrease concentrations of the active metabolite of oseltamivir. So ultimately, this could lead to a less beneficial response from using oseltamivir. So again, it's kind of controversial in the literature, but there definitely are numerous patients that do take clopidogrel. So I did want to mention that. The thought, the mechanism potentially is inhibition of human carboxyl esterase is how oseltamivir is actually activated to its active metabolite via that enzyme. I think that's going to wrap it up for today. Thanks so much for listening. If you enjoy the show, have picked up some pearls, definitely leave us a kind rating review on iTunes. I'm greatly appreciative of all the folks that have taken the time to do that. That definitely helps us grow the audience and certainly share medication education throughout healthcare professionals. So that's appreciated. reallifepharmacology.com, you can subscribe there and get a free 31-page PDF. It's on the top 200 drugs, a great resource for healthcare students and young professionals for sure, where I lay out clinical pearls for the top 200 drugs, are really important things that I've seen come up on exams as well as in real life. So certainly go check that out. If you're inclined, definitely go support our sponsor, meded101.com/store is the link that you can go to find everything we've got there. And I'm going to sign off for today. Thanks so much for listening, and have a good rest of your day.